Ladies and gentlemen, thank you for your patience in holding. We now have your presenters in conference. Please be aware that each of your lines is in a listen-only mode. You may submit your questions at any time electronically using the Q&A pod located to the left of your slide deck. Underneath that, in the resources window, you'll be able to download a PDF copy of today's presentation. It is now my pleasure to introduce today's first presenter, AHA moderator Drew Solo.
Thank you, and welcome everyone to today's webinar. This is Drew Solo with Health Forum, part of the American Hospital Association. I'm pleased to be moderating today's event, Improving Emergency Department Operational Efficiency. This webinar is brought to you through the generous support of Philips Blue Jay Consulting. FirstHealth Moore Regional Hospital was looking to assess a decline in emergency department ED volume, reduce a high left without being seen, or LWBS, rate, and fill an unexpected vacancy in its ED leadership team. The hospital worked with Philips Blue Jay Consulting to conduct a comprehensive ED assessment, implement targeted performance improvement processes, and provide interim ED leadership. As a result of their engagement, FirstHealth Moore Regional Hospital has been able to sustain improved ED operational performance and an enhanced patient experience. Let me introduce today's speakers. Karen Robiano is the Vice President, Patient Care Services and Chief Nursing Officer for FirstHealth Moore Regional Hospital in Pinehurst, North Carolina. She has over 20 years of experience as a Chief Nursing Officer at both medium and large hospitals in Ohio, Texas, and North Carolina. She has been intensely involved in emergency department throughput and patient flow throughout the hospital since joining Moore Regional in 2013. Dan Hannon is a Senior Consultant for Philips Blue Jay Consulting. Dan's extensive experience includes more than 30 years of emergency department clinical care and leadership within community hospitals, freestanding emergency departments, as well as large academic health systems. He has a variety of leadership roles within the Cleveland Clinic Health System, as well as serving as a nurse informatics manager and chief nursing officer within the University Hospitals Health System in Cleveland, Ohio, prior to joining Blue Jay Consulting in 2013. And our third presenter, Dr. Matthew Harmody, is practicing emergency physician and president of Sand Hills Emergency Physicians, or SEP. SEP provides emergency department coverage for all four FirstHealth hospitals in Pinehurst, Troy, Rayford, and Rockingham, North Carolina. He serves as the medical director for the Pinehurst and Rayford EDs, as well as the EMS medical director for FirstHealth of the Carolinas. Dr. Harmody received his MD from Case Western Reserve University in Cleveland and completed his residency training in University of North Carolina Hospitals at Chapel Hill. It is now my pleasure to turn the floor over to Karen Robiano, who is today's first presenter.
Great, thank you, Drew. First, I'd like to tell you just a little bit about FirstHealth Moore Regional Hospital. Moore Regional is the flagship hospital for FirstHealth of the Carolinas, which is a health system located, I say, about an hour south of Raleigh in beautiful Pinehurst, North Carolina. It is a 402-bed referral center for 5 counties in our primary region and an additional 10 counties in our secondary region. In 2018, FirstHealth Moore Regional was named one of America's Great Community Hospitals by Becker's. We do provide most specialties, including a very large orthopedic practice, obstetrics, inpatient behavioral health, cardiology, including open heart surgery and TAVRs, and we have achieved both a stroke center and a bariatric center of excellence. Some key statistics about us: our average daily census is approximately 290. We do about 23,000 discharges per year, 12,000 surgeries, 2,000 deliveries. Our case mix is running about 1.93, and probably most importantly for this conversation, our ED visits run about 60,000 per year. Okay, so what I'm going to do now is describe what I called the perfect storm. With the opening of our 8-bed hospital in Rayford, and it was an 8-bed hospital with an 8-bed emergency department, Rayford is in one of our primary counties. We then experienced about a 1.8% year-over-year ED volume decrease, and yet our left without being seen rate remained high at over 2%. In addition, we were looking at our statistics through CMS and saw that our length of stay for both admitted and discharged patients was significantly higher than our peers. We were also getting ready to implement a new electronic health record. And then the final blow, we experienced an unexpected ED leadership vacancy. At that point in time, we then had several months where we continued to experience an ever higher climbing left without being seen, reached a high of 6.46%, which we calculated to represent a lost opportunity of approximately $10 million in potential collectible revenue, and we knew we needed to do something different. Probably for me as the Chief Nursing Officer, one of the things that gave me the most angst is that our left without being seen rate had become a topic at most of our board meetings, and all of our previous efforts for improvement either failed or were unsustainable. And I felt like we were gerbils running around the track. So we were looking for resources, and interestingly, the CEO, the COO, and myself all received on the same day literature from Philips Blue Jay about improving emergency room efficiency. So after a quick huddle, we all decided this couldn't have come at a better time, and we really needed to look for some outside help to help address the perceived process and performance efficiencies in our emergency department. We also needed an interim leadership to fill our nurse manager vacancy, especially with the EHR implementation rapidly approaching. I will tell you, Philips responded very quickly, set up an on-site team in record time, I felt, and they came in for a 2-week assessment. This assessment was very thorough and actually didn't really reveal any surprises. They shared with us the good, the bad, and the ugly. They did recommend, in my mind, the perfect interim manager who was a certified EHR trainer, and she was able to ensure a successful transition to our new system. So the assessment leveraged data analytics, and this was all based on data that we provided Philips Blue Jay regarding our current performance prior to their on-site visit. And then once on-site, they performed staff interviews, team shadowing, and patient flow observations, and they were here at all hours of the day and night. The assessment revealed considerable variation in care processes, which were probably made worse by the recent unexpected leadership vacancy, as well as us being in the final planning stages of the major electronic health record implementation. And just one note, we were going from what was an emergency department-specific electronic health record to a hospital-wide electronic health record. So there was a little bit of resistance, I would say, from our emergency department as well. Philips Blue Jay truly engaged our leaders and our staff throughout the entire assessment, and it was a very positive experience. Even when they were sharing the not-so-pleasant things, we all felt like we were in the boat rowing together. Our consultants worked to recommend and develop and then implement process changes. There were several areas that were identified as our biggest areas for opportunity, and you can see those there. Pretty much that whole arrival, reception, and triage process needed to be blown up, patient throughput, and then also leadership development. So based on the assessment results, we did request dedicated performance improvement program from Philips. We were able to select our PI consultant, who was Dan Hanna, from a list of very experienced, highly qualified ED experts. And our changes were directed at front-end optimization, direct vetting, the emergency severity index training, and then split flow redesign. So at this point in time, I'm going to turn it over to Dan to discuss the improvement processes.
Thank you, Karen. Welcome, everyone. Good morning and or good afternoon. It's a pleasure to have the opportunity to share some of our strategic initiatives to improve performance at Moore Regional Health. And I'm going to start by describing some of the front-end process improvements. So based on our assessment findings, as well as observations from the previous mentioned interim clinical manager, front-end processes including patient arrival, reception, and triage was a natural starting point. Concerned that initially that a non-clinical receptionist was a patient's initial and only contact upon patient's arrival to the ED, we implemented a first look nurse. The role was created through reallocation of existing nursing resources, and that the role assures that a skilled RN is performing an assessment immediately upon the patient's arrival and takes place in parallel with quick registration processes. So working with registration, we noticed that there was a number of registration areas which were frequently associated with language barriers, which, as we all know, result in downstream potential patient safety, HIPAA, and billing issues. So the quick registrations processes have been enhanced to include positive patient identification and implementation of e-signature processes. So whereas in the past patients followed a very serial process of registration followed by triage assessment followed by vital signs within the arrival area, we looked at the direct bedding process. Some of you may know it as the pull-to-full or immediate bedding. So we implemented this to allow patients to bypass these initial processes. So when a treatment space was available, patients are placed directly into the most appropriate space where primary triage and bedside registration occurs. So they bypass that whole front-end serial process. So in addition to a significant shift in the departmental culture with this change, this required some redefinition of processes as well as a standardization of primary and secondary triage and the documentation associated with those processes. So primary triage has been redefined, and it's limited to a brief patient assessment, including basic vital signs such as pulse rate, pulse ox, pediatric weights, and temperature as indicated by nursing judgment, as well as an ESI level assignment, which I'll speak of shortly. Whereas secondary triage encompasses the more comprehensive history and physical assessment, as well as the mandatory screenings such as screening for abuse, smoking, alcohol use, etc., and those are performed by the primary nurse at the bedside. Revision and hardwiring of previously established and basically underutilized rapid triage protocols, which were approved by the medical staff, allow nursing staff to initiate care prior to the patient being seen by a medical provider based on the nurse's assessment. And then again, as identified in the assessment phase discussed earlier, there was a significant inconsistency in assigning acuity scores to patients when they arrived. The front-end process standardization, in addition to the staff training related to the Emergency Services Index guidelines, really improved the alignment and consistency in acuity scoring among nursing staff. So let me talk a little bit about the ESI training. So to build this consistency, we committed to educate 100% of the ED nursing staff on and if you're not familiar with it, the 5-level Emergency Severity Index, also known as ESI triage system. So this methodology is evidence-based acuity scoring methodology based on an ED triage algorithm which stratifies patients into 5 groups based on their acuity and the resources needed for their care. We used the 2012 4th edition of AHRQ's ESI Implementation Handbook as our guiding principle, and it provided 9 4-hour triage training sessions over about a 4-week period. The training included a pre-test initially to measure baseline existing knowledge of the nursing staff. We presented case scenarios, classroom and real-time competency validation, which we thought it was important to include both clinical as well as behavioral performance expectations of that triage nurse, and then followed up the class upon completion with a post-test just to validate the level of learning. Following that, we utilized inter-rater reliability methodology to assess the external consistency of triage scoring with each trainee, and then followed that up with the Train the Trainer course because we weren't going to be there forever. So to maintain sustainability, we did the Train the Trainer course, which would require some oversight of the ED leadership and clinical educator. So there was some coaching and mentoring that needed to take place with the new leadership team, and I think Karen, you'll discuss some of that process.
Yeah, so our previous structure, we had the nurse manager and then we had 2 clinical nurse leaders. One was on days and one was on nights, and they primarily worked 3 12-hour shifts, which left us with a lot of gaps. And many of the changes that Philips Blue Jay had recommended were things that we had looked at before, but we had just never really gained traction with them. So in speaking with Dan, we felt it was important to have more accountability and decided to go with the clinical nurse leaders having somebody 24/7. So we created 2 additional positions. So we had 2 on days and 2 on nights, and really wanted to focus on increasing communication, making sure that we stayed targeted on throughput, but then most importantly, really establishing increased accountability for the process changes we had put in place. Our PI consultant, Dan, supported their transition into the new role, really had to help them understand how their role was different than just a charge nurse, and making sure that they focused on operational oversight and evidence-based practice, safety, quality, risk reduction, and cost containment. And frequently had to remind them that they weren't just charge nurses, that they were really responsible for the big picture of the emergency department. We use standardized data and analytics, and the PI consultant taught them how to use that data for real-time interventions. We implemented a visual management system to help create transparency with those. They also provided some coaching and mentoring to help them understand the resource management, the change management principles, and also managing crucial conversations and conflict intervention. So I would say that that has been key for us sustaining this, is to have leaders there 24/7 and making sure that they are understanding the data and using the data to help drive decisions. And now I'm going to turn it over to Dr. Harmony, who will summarize the split flow and vertical care processes.
Thank you, Karen. Another opportunity to improve the patient experience included implementation of a split flow vertical care model. This philosophy suggests that the low acuity patient who arrives vertically will remain vertical as much as possible while being treated fully and efficiently, but not assigned to a bed. Working collaboratively with the ED physicians and the APPs or mid-levels, the team developed a robust inclusion and exclusion criteria for split flow vertical care treatment to assure that the right patient was in the right place from a safety and efficiency standpoint. We were able to accomplish this because we were successful in re-educating and validating our ESI training, as mentioned earlier by Dan. Chief complaint-driven protocols were updated and the staff educated and encouraged to utilize their critical thinking skills, which increased utilization of these protocol orders to initiate care prior to the patient being seen by a provider. As part of this process, we relocated the APP workstation to near the intake nurse. While this technically was not a provider and triage design, it did allow for greater collaboration between the APP and the intake nurse. This allowed for real-time interaction earlier in the assessment process and was especially critical during the initial workflow change. Patients were directed to a dedicated private area to discuss their chief complaint with either a nurse practitioner or a physician assistant working under the direction of an ED physician. A brief private exam was completed and ancillary testing initiated. Rather than placing these patients in a treatment room, they were escorted to an existing underutilized sub-waiting area to await their ancillary testing. Here they remained until testing was completed, which was followed by a reassessment, treatment, and disposition. Specific talking points were developed to reassure patients that while they were moving through the patient care process quickly, this was being done without compromising safety and/or quality. A vast majority of the patients appreciated these explanations and any attempts to make their care more expedited. While these patients were typically ESI level 4 and 5s, we were able to expand the split flow model to include what we refer to as vertical 3s, or less acute ESI level 3 patients. This approach was typically implemented during times of high ED patient volumes. In the case where an APP assessment determined that a more involved or time-consuming workup was warranted, the patient was transitioned to either a high or acuity ED bed or to a procedure/treatment room. Depending on the patient presentation, care would continue to be managed by the APP or turned over to a physician. This helped prevent the front-end process from becoming bogged down. I'll turn it back to Dan now.
Thanks, Dr. Harmony. So lots of changes in a short period of time. So as we all know, as with any process change, staff education and communication are the keys to success. So we were very diligent in communicating the plan across all disciplines, all stakeholders to drive engagement and ultimately sustainability. We were fortunate that the clinical educator, who, while experienced as a clinical educator, was new to the organization and very gung-ho about creating process change. So she was embedded immediately into our project teams. She brought a fresh perspective, reinforced the importance of process consistency. She also worked as a staff nurse in the emergency department occasionally, so there was a different level of engagement with the staff. So she was able to champion progress at daily staff huddles, team meetings, and staff meetings. And since this was a peer-driven process, the staff played such an important role in developing and implementing these new processes. We felt that it was important that for the entire staff to be aware of positive results. So we developed some visual management processes so that we could post results and transparency. And interesting to watch the bidirectional communication. We encouraged that, and it did occur. Peers began to hold each other, actually holding each other accountable for the processes, for utilization of the communication devices that we integrated, for the scripting that we developed as a team, and really maintaining a focus on the patient. Anytime as our teams met, if somebody said, well, that's hard for the nurse to do, we try to reflect back and say, okay, what's best for the patient? Because this is again, very patient-driven process improvement plan. And on a personal note, just as a side note, as an objective observer, I have to tell you, it was very exciting for me to witness the cultural transformation with the improvements in communication and the willingness of staff to openly share opportunities and challenges among nursing and medical leadership. And I witnessed an overall enhancement in trust between departments and the various disciplines. So I think next I will go into some of the results of the process improvement and this, as I mentioned, the patient-centered cultural shift. So reviewing the outcomes on the slide, you'll see associated with the performance improvement collaboration with Moore Regional Hospital and Philips Blue Jay Consulting. As stated earlier, 100% of the ED nursing staff was educated and their competency was validated on the use and implementation of 5-level ESI triage system, and the plan to assess this consistently at regular intervals into the future to prevent any backsliding, as well as to keep any new employees on the same page. Next, improvements related to the front-end process optimization, starting with the implementation of the first look nurse. So in addition to improving patient safety and quality of care as patients present to the ED, from a metric standpoint, the arrival to triage interval realized a 62% reduction from 13 minutes to 5 minutes. So arrival door to triage dropped by 8 minutes. If you quantify that 8 minutes by, let's say, an average of 164 patients per day, that's a significant, about 1,300 minutes of patient waiting reduction just at the arrival phase of the ER per day. And then with the implementation of the direct bedding process, we saw 169% increase of patients being placed immediately into a treatment space from a baseline frequency of 24.3% to an improvement of 65.3%. And the arrival to bed interval going along with that was reduced by 87% from an average of 31 minutes to 4 minutes, which is obviously patients show up to the emergency department. They don't want to spend time in the lobby. They want to get to a patient room. So that was very popular with the patients. As a direct result of the direct bedding, physicians and providers had access to the patients much more quickly. So that in turn reduced the arrival to provider interval from what was a baseline of 47 minutes to 17 minutes. So the providers were getting in much quicker to examine the patient, order the tests, and then later down the line, EMS arrival and ED radiology processes were addressed a little bit later, and Dr. Harmony will discuss those with you shortly. So to talk about the split flow model, it demonstrated positive outcomes in length of stay reductions for our low acuity patients, and obviously had a cumulative improvement effect in our overall ED discharge patient length of stay. Our length of stay for our ESI-4 patients declined from a baseline of 207 minutes to 113 minutes on average, and our ESI-5 patient length of stay saw a decline of about 33 minutes per patient. And so the impact on overall length of stay for all discharged patients declined from 190 to 161 minutes. The first look nurse and direct bedding initiatives resulted in a significant, an 83.6% reduction in the left without being seen rate, as we discussed earlier, from a really high 6.46% to a better than industry average of 1.06%. And I think the most significant finding with the left without being seen reduction was the percentage of patients who left without being seen prior to triage. That was significantly reduced. And I think the fact is placing patients in a bed as opposed to leaving them in the lobby, patients are much less, in my experience, patients are much less likely to leave without being seen once they're in a patient room, whereas in the lobby, it's just much easier to walk out of the department. So that left without being seen before triage rate dropped from 22% to an average of only 8%. And as Karen had mentioned, the clinical leader team, in my opinion, demonstrated significant professional progression in their transition into their new roles. They became increasingly analytical in driving processes and accountability in real time, as well as they were extremely responsive to coaching related to resource and change management, as well as conflict reduction and intervention. And I think this was a key. Their receptiveness to all of this change while learning a new role really helped progress forward. And last, but certainly not least, before we move forward, as a result of these process improvements and the cultural transformation, our patients were much more satisfied with their care experience. And as you can see, our overall rating of ER care improved by 95% from an initial percentile ranking of 37 to the 72nd percentile. And we believe, based on the data, that this was strongly associated with the process improvements. So as I said, Dr. Harmony is going to share with you some additional information about additional initiatives and what's happening to sustain what we've put together.
Thanks, Dan. So based on the success of our process improvements, we asked Philips to extend their consulting agreement with us. The specific goals were threefold. First, we felt it was critical to assure that the processes were hardwired for sustainability. Second, we had initiated plans for additional process modifications to improve radiology inefficiencies based on previously identified barriers to flow. Third, based on feedback from our community pre-hospital providers, we assessed our current arrival processes and patterns for EMS patients. We really needed to create a more coordinated and patient-focused arrival process, which also served to expedite EMS provider availability back into the community. So I'd like to just give two brief examples. Regarding radiology processes, while turnaround times for CT and plain radiography were efficient, we quantified significant delays in patients awaiting ultrasound procedures. We had always known anecdotally that ultrasound turnaround times were lengthy, but now sharing objective data with our radiology colleagues allowed us to jointly develop an improved workflow there. Regarding EMS, one obvious flow constraint that was identified involved crews waiting to check in with an ED registrar near the ED entrance before proceeding to an assigned room. Oftentimes, the registrar was not available immediately. This led to delays and frustrations on the part of our EMS colleagues. The simple solution, which was one of many, was to utilize our EMR and display an EMS arrival monitor at the EMS entrance. This allowed an incoming EMS crew to identify their corresponding ED bed and proceed directly to a patient room upon arrival. Report was given at the bedside, followed by the initial patient triage and assessment. ED registration was initiated at the bedside shortly thereafter. In summary, to maintain a philosophy of continuous improvement and facilitate process sustainability, Dan returned to Moore Regional 6 months after the initial project completion to observe and guide process flow according to previously established guidelines, as well as identify any barriers that may negatively impact sustainability. Dan provided a comprehensive report of his findings and follow-up recommendations, and will be returning to Moore Regional at the 12 and 18-month marks. Drew, I'll turn it back over to you.
Great. Thank you so much. Thank you, Karen Robiano, Dan Hannon, and Matthew Harmody for your presentation. We will now begin the question and answer portion of today's event. As a reminder, you may submit a question for our speakers in the question and answer box to the left of the presentation. Simply type your question in the box and hit submit. Our speakers will answer as many questions as possible in the time remaining. Questions that are unable to be answered in our allotted time will be shared with the panel for follow-up offline. So, first question here for Karen. What determined the decision to obtain outside help?
The reason we went with outside help is because we had tried many things on our own. You know, we had read the literature and said, okay, we need to do quick look, we need to do split flow. We tried a vertical room, but we were not able to sustain improvement and frequently went right back to the same processes before. We didn't have, I would say, either staff or physician buy-in, and the outside consultants were really able to work with both the physicians and the staff as active participants in the decision-making, and I think that's what stuck.
Great. Another question for Dan. Dan, what was the key element in changing the culture to be more patient-focused?
So I think for me, from my perspective, I think embedding myself with the staff initially as an ER nurse, they understood that I knew what they were going through. And as I said earlier, I think during our team meetings, anytime when we looking at our process improvement, we first defined our current state. And then we talked about future state, but we stuck with the philosophy that in future state, we're going to look at things from a patient perspective. We have to discuss and we have to consider how it impacts the employees and the rest of the hospital. But basically, anytime our discussion went in that direction, we brought it back to what is our ideal state from the patient's perspective. So if that patient was your mom, would she want to sit in the waiting room? Would she want to follow this serial process, or would she want to go directly back? So I think once we created that environment within our team structure, we had a great team, and I have to say this, that the administrative support through Karen and the C-suite and the physician support driven by Dr. Harmody, that was a key to our success. I think it's well known that when you're working with so many different people, you may have difficulty engaging all of them. So engaging the medical staff, the mid-level providers, was key to this, and making sure that we philosophically were all on the same page with future state equals what's best for the patient.
Great. Dr. Hermody, do you have other support staff in your ED, like lab, radiology, respiratory, etc.? And if so, what role, if any, did they play in this process?
So that's a great question. We are set up with emergency department secretaries as well as nursing assistants as what I would consider, permanent team members in the department. We also have dedicated radiology staff in a dedicated radiology suite for plain films and CT imaging. And I talked a little bit about how they were involved with the process as kind of a secondary step, and they attended our regular meetings and helped us work through a lot of the issues and processes, because otherwise you can't understand everyone's perspective without all parties being in the room. And then thirdly, and just stepping further away from the emergency department, we have respiratory therapists and EKG techs that are not necessarily dedicated to the emergency department, but one is somewhat assigned to the area 24/7. They obviously were a little less involved. They're already very responsive, and in times with the increase in direct bedding, they were very easily available to be in the patient room either in advance of the patient arriving or at the time when the patient was direct bedded. So they were a little bit less involved with the process changes, but had no difficulty keeping up with what we were trying to accomplish.
Okay, great. Karen, I have another question for you. Karen, what improvements did you attempt in behavioral health?
Wow. Behavioral health, we have a lot of behavioral health holds, and we have an inpatient unit, but frequently are at capacity or the patient is not appropriate, whether they're an adolescent or a child, and we did find that was impacting our capacity. We have been collaborating with behavioral health, the team in behavioral health, just to get the patients placed as quickly as possible. And I will tell you that, our case manager that we had in the emergency department spent a lot of time previously calling our left without being seen to follow up on them. And with the decrease that we have sustained well below the 2%, she has more time to really focus on getting resources for the patients that need those community resources in order to be discharged out of the emergency room quicker.
Okay, great. Dan, how long did it take to achieve the results that were mentioned?
I would say overall, from start to, I don't want to say finish because it's not a finished product. It's something, and it's an ongoing process. But I would say between 4 and 6 months. Actually, we started with 2 different teams. One was going to be the front-end process improvement team, and once that got up and going, we were going to implement our split flow team. And as we were working on the front-end team, we realized that there's such an overlap between the 2 teams that we probably made it a little bit more difficult on ourselves, but it just made sense to pull all the processes together. So I would say within about 2 months, through rapid cycle testing, we had a pretty good process going with the first look nurse and the quick registration and the direct bedding. And then again, with the rapid cycle testing, we agreed that we weren't going to make any changes along the way until we debriefed about what we were experiencing and some of the other thoughts we had about improving. And then a majority of the time was sustaining the remainder of the 4 months was sustaining that front-end process and driving that, as well as putting together the fast-track split flow vertical care model, which that involved a lot more people, because that's when the nurse practitioner and the physician assistant and the physician came into place. So that took a little bit longer. So I would say about 4 to 6 months before we really thought, wow, we've hit a home run, but we haven't won the game, so we got to keep on playing.
Okay. Dr. Harmony, what percentage of discharge calls are made post-ED discharge, and do the ED nurses make these calls during their scheduled shifts, or does this represent a quality position FTE?
Another great question. I would say that effort, which is an important effort, is accomplished by the divide and conquer method. We have, I would say, 3 primary groups of folks that make those calls. One, starting with the charge nurse and or the clinical nurse leader, call all of our left without being seens and also make some clinical callbacks. Those may be tests that resulted the following day, for example. The second category of patient callbacks involve using our outcomes management nurse. She gets a wide variety of opportunities to call patients back. We have in our EMR a method where we can consult her at night or over the weekend, and with a request to call a particular patient for any variety of reasons, from needs in the home to getting follow-up for a home health nurse, for example. And then thirdly, the physicians make some calls. We encourage our providers and APPs, for that matter, to call patients that may have been a somewhat difficult discharge, or maybe the patient opted to go home versus following a recommendation for admission. So I couldn't really quantify what percentage of those patients that makes up of our discharge patients, but it's certainly the more critical group of patients that are discharged, and certainly at a higher risk of returning unexpectedly.
Okay. Karen, how does the utilization review RN and case manager play into this?
Well, primarily the focus for them is getting the patients the resources they need, and that really hasn't changed. We did go from our case manager was a nurse, and we also had a utilization review nurse. Now we have a social worker and a utilization review nurse. And so the one spends most of her time on community resources, securing those for the patients, and the other one really looks at the appropriateness for admission and what level of admission they should receive. So I would say they were probably the least impacted by these changes, but it gave them more time.
Okay, great. Dan, can you share some tactics that help decrease the LWBS, or left without being seen?
Sure. Again, having the first look nurse out in the front when patients presented, as opposed to a non-clinical person, the first look nurse. So the first look nurse role, I saw that there was another question about first look nurse role. So basically, the first look nurse role was to eyeball patients, use their critical thinking skills, the training that they received in ESI, and make a quick assessment of patients. Are they sick or are they not sick? If rooms were if we couldn't direct bed, they would, and there wasn't a line forming into the ER, they would spend a little bit more time with the patient doing a full set of vital signs and maybe a history and physical. And the other thing that we talked about with the first look nurse is, inevitably a line is going to form. And the role of that nurse, in the past, it was just a serial process. So patient one would come to the desk, followed by patient 2, followed by patient 3. Our concern was, what if patient number 5 is having an acute situation and the receptionist doesn't, from a non-clinical perspective, doesn't recognize that that's an acute situation. So part of the first look nurse role was to, as patients presented, to not to excuse themselves from their current patient, do a quick assessment of each patient as they walked in the door, just to make sure that somebody with, you know, maybe not very specific symptoms wasn't having an acute episode. So back to the left without being seen, I think having the nurse see patients as they walk through the door, you've created a clinical relationship between clinical staff and the patients. In addition to that, the bedside registration, as I said earlier, people are much more likely to leave without being seen from the lobby as opposed to once they get behind the magic door of the emergency department. So, and again, so with direct bedding, they got into a room more quickly and they were seen by the physicians more quickly. So I think all those pieces really put together resulted in the left without being seen improvements.
Okay, great. Dr. Hermody, another question for you. What are some best practices used in the diagnostic imaging modalities to help expedite throughput in the ED?
Yes, we had, when we entered that stage of the work in looking at our process flow for radiology in general, we really, quite honestly, had a hard time finding national metrics or standards. Even our radiology colleagues had some trouble finding those. We typically used metrics in-house. In other words, we looked at kind of our best practices and when things were going well as far as establishing turnaround time goals. Talk a little bit about ultrasound. I'll share with you just maybe a few anecdotes. Ultrasound in particular was kind of a circular delay in that most of the patients requiring ultrasound that led to delays were usually young females. And of course we had to determine their pregnancy status. So they would, of course, provide a urine specimen for that and empty their bladder. And then shortly thereafter we'd expect them to have a full bladder so that ultrasound could be performed accurately. So we instituted just really simple things such as encouraging all the women to drink fluids almost right off the bat once we realized we would need ultrasound imaging as part of their evaluation. And secondly, we worked with our radiology colleagues in eliminating a transabdominal ultrasound as part of that evaluation. So they were doing simply transvaginal studies as a part of that improvement, and this led to not requiring a full bladder for the transabdominal ultrasound and therefore not requiring time to have the patient consume either fluids or IV fluids and delay ultrasound in that regard. With respect to plain imaging and CT, it really is just it's always been pretty standard, strong turnaround times. I would say that communication is the key. Usually our plain film staff were almost outside the door within a few minutes of when the plain film study was ordered, and just communicating with the nurses. We usually kind of had a pecking order. It usually was line in labs, medications if needed, and then plain film. So they worked well together to make sure that that process went in that order, or if the radiology tech wanted to substitute, they may, they'll ask the nurse if they could take the patient prior to the nurse accomplishing all of his or her tasks. CT, we just had people bird dog. Probably the most limiting factor there is if we're giving IV contrast and we're waiting on a creatinine value. The CT techs were, they just had access to the labs. They helped bird dog and they would see when the creatinine was back, and as long as that was within a acceptable limit, they would be pulling the patient to the department instead of the physician or someone else finally wondering why the CT wasn't performed and realizing the labs were back, but that no one recognized that they were back. And as you can imagine, those delays just compound themselves. So those aspects of imaging worked well, and we tried to address, like I had said earlier, where we were really having some struggles with turnaround times.
Okay, great. Dan, question for you. Did you see any effect on the throughput times?
Absolutely. So as I mentioned earlier, when we put the split flow model in place, not only did we see a reduction in the level 4 and level 5 patients, but a cumulative effect on the overall discharge length of stay. I believe it was from 190 to about 160 minutes. So shaving off on average 30 minutes per patient basically increased our capacity. Without any construction, our rooms were just much more available because we were able to turn patients over much more quickly. So yeah, about a 30-minute reduction in discharge length of stay overall.
Okay, great. Karen, was your clinical educator dedicated to the ED or part of a hospital-wide education department?
She is dedicated to the emergency department, and that came from staff input that they really felt they needed certain education that I felt a dedicated educator would be able to provide.
Okay, great. And it looks like we have one last question here for Dr. Harmody. What impact would the ability to triage patients en route to your ER via virtual video have on the ability to manage staff, consider diversion based on ER waiting room, and critical nature of patients already in the emergency room?
That's a great question. Never really thought much about that, but I would say that we have a very robust pre-hospital notification system. I think providing additional information through a visual aspect certainly could improve upon our system, albeit it is pretty strong. From an acuity standpoint, we do a pretty good job of rearranging the deck chairs when we're full and there's a high acuity either EMS patient or patient presenting to triage. That communication is very important and is generally very effective. But no, that's an interesting concept. I think it certainly could help in a lot of regards. And finally, I would add that, at least in our circumstance, we're a fairly large community hospital, somewhat in the middle of nowhere. So at least our in-county EMS agency does not divert under any circumstances. It would be at least a 45-minute additional transport time to our nearest like-sized facility and an hour plus in other directions to other likewise or larger facilities. So we have never gone on diversion, quite honestly, and we actually, in probably extreme cases, we may ask our own regional hospitals, EMS agencies in surrounding counties not to divert from those smaller facilities if we're really backed up. But like I said, we never divert because of our geographical circumstances and our surrounding comparable hospitals.
Okay, great. Well, that concludes the time we have available for questions. In the next few days, all attendees will receive an email that will include the link to the archived webinar session. Also, please take a moment to fill out our quick pop-up survey momentarily. Thank you to our audience for joining us, and thank you, Karen Robiano, Dan Hannon, and Dr. Matthew Harmody for your presentation, and thank you to our sponsor, Philips Blue Jay Consulting. Thanks again for joining. That concludes today's program. Have a wonderful afternoon.
Ladies and gentlemen, that concludes today's presentation. You may disconnect your phone lines, log off your webinars, and thank you for joining us this afternoon.